was a little worried it was going to be just myself and the rest of the panelists here at this point in time. I still have no disclosures over the past 2 days. Just to give you a little roadmap here of where we're going with nitrous, going to spend just a few minutes, a few slides on the history, how we got to where we are today, a little bit about efficacy and satisfaction in women who've used nitrous, some safety data, both maternally and for the neonate, and then should you be in a group that wants to set up nitrous, some just practical tips on what you should be thinking about. Okay. So to begin, we'll go back to the 1700s. Joseph Priestley, I'm sure you've all heard the name, was the first to synthesize nitrous oxide. But really at this point in time, it was more of just a party trick. The gas was used, put in balloons, inhaled at parties. Some of that still goes on today. Part of what I did when I put this talk together was try to think about questions I got both from patients who use nitrous with us, as well as groups that have contacted me in the past year or so about setting up nitrous. And one of the questions I get from patients is, I thought nitrous was bad, I heard it could cause brain damage, it's a drug of abuse. And really the difference between what we're doing is ours has significant amount of oxygen in it, whereas at parties it's often put in balloons and there's a hypoxic brain injury that can occur when you just inhale 100% nitrous, as opposed to the 50% that's typically delivered for labor analgesia. It was really in the late 1800s it was first used for labor pain relief. And this individual, Stanislav Kurklovich, took detailed notes in one of his studies on 25 women that he had given nitrous to for labor pain relief. And the interesting thing in going over an article that had these 25 women's notes was that a lot of the things he found still hold true today regarding the delivery. He noted that the laboring woman needed to breathe the nitrous for ideally almost up to a minute prior to the contraction to get good pain relief. If you had someone who was in the second stage and was having to hold their breath, trying to get a good 3 full breaths in before they started to hold it and then push. Okay, where are we today? Well, as of right around somewhere between 2002 and 2012, I have mixed data, but in the US, nitrous is used less than 1% of the time. And I will say significantly less than 1% of the time. Up until 2012, there had been a significant period of time where delivery equipment for nitrous for labor just didn't exist. There were only 3 academic institutions in 2012 that still used nitrous. UCSF was one of them, Vanderbilt, and University of Washington at Seattle. And we had just kept our equipment through this period, and we had great biomed technicians that kept it running for us. If we go way back to the 1930s, nitrous was actually used quite a bit more in the US. The problem was back then it was delivered in higher concentrations, 70 or 80%. It was often mixed with other drugs, opioids. Twilight sleep was very popular at that time, which was scopolamine and morphine mixed then with inhaled nitrous. So you can imagine a significant amount of loss of consciousness with these regimes, some vomiting, some aspiration. And then it was around in the late 40s, 50s that neuroaxial blockade came around. You had the benefit of not having this extreme sedation. Really in the 80s and 90s, the lumbar epidural for labor pain relief really took off, and consequently in the US, nitrous just fell away. Back in the early 2000s, about 7% of the US was using nitrous, and now we're at the 1% today. This is in great opposition to other parts of the world in the English-speaking countries, Canada, Finland, Sweden, the UK. I didn't put Australia up there, but it falls in these numbers. Significant amount of laboring women use nitrous, half or more than half. It's in all the delivery suites. It's used very commonly. So why did nitrous work so well for Europe? Right? Well, a lot of inhaled agents had been tried, from methoxyfluorine to cyclopropane to even recently sevoflurane, desflurane, and so on. nitrous has some really ideal properties, right? Odorless, colorless, difficult to burn, very low blood solubility, which allows it to reach effective levels relatively quickly, within a minute. Low metabolism, less than 1% is metabolized, and there's a benefit to having a relatively low anesthetic potency compared to those other gases I mentioned. How does it work? Even though it's been around well over 100 years, it's still really poorly understood. We feel that it works in the gray matter of the midbrain and then affects the descending spinal tracts in the dorsal horns. You have release of endorphins, corticotropins, dopamine, and it even blocks some of the NMDA receptors. When you talk to patients who've used nitrous for labor, and you ask them a question such as, how's your pain now that you're on nitrous compared to prior to me initiating the nitrous, they'll often give you a pain score which is very similar, if not identical, but then they'll say they care about it less. And that's sort of the effect we see, is that it's not so much the analgesia, it's this almost dissociation from the pain where they can tolerate it better. So before I begin on the studies regarding nitrous efficacy, in my handout, there's probably 4 or 5 very good systematic reviews that have been done just in the past few years. As equipment became available again in the US in 2012, I think is what spurred a lot of these reviews. And so this is a very recent one from ANA. And I put the conclusion up there first before even giving you any of this data, basically saying that the literature looking at nitrous oxide specifically for labor pain has very few studies of good or even fair quality. And we really need more research across every single area from efficacy to satisfaction to safety and adverse events. Okay. Why, if it's been around for so long and so many people use it in Scandinavia, Canada, Europe, so on, why don't we have any good studies? Part of it is lack of standardization. Different nitrous concentrations, there's still concentrations up around 70% that are used in Australia as opposed to the 50% now. I have studies using as low as 30% up to over 80%. Different methods of delivering the nitrous, from inhaling it sort of in a mouthpiece to using a face mask. Continuous breathing of the nitrous to intermittent, different pain assessments, comparison groups. Most of the studies don't compare women with nitrous to women who didn't use nitrous. They compare women with nitrous to all sorts of other things, all these other inhaled agents, different IV agents, and so it's really tough to tease all this literature out, which is why we are where we are, needing much better studies. Okay. So here we go with some of the data that we have. I wanted to start out giving tribute to the anesthesiologist that trained me, Dr. Rosen, way back in 1969, did a study in South Wales and looked at 265 patients there who were using nitrous and just asked them after their labor and delivery, how did it go? How was your pain relief? You can see the numbers there. About 10% said it was great. I got complete pain relief. There were about almost 30% that said, didn't really know you were giving me anything. It was slight or non-existent. And then the majority were somewhere in between there. Asked the same question as the midwives, and you see that 90% felt it was excellent, good, or adequate, with only 10% feeling it was inadequate. So a big movement there to nitrous works about 90% of the time from the midwife's perception. Okay. We'll move forward now to 2006. We have a study out of Sweden, almost 2,500 women who gave vaginal delivery. And the first thing I want you to look at in the slide is the percentage of women using nitrous. Over in the far right-hand column, second from the top, 80%, right? It doesn't mean you were allowed to be in more than one category in this study, but 80% of the women in this study in Sweden, a huge study, used nitrous. Okay, so how did we do? Well, if we look at the PRIMEPs, you can see that about a little under 40% said it was really effective, Around 15% said didn't get much effect at all. This is in big contrast to the epidurals, like we know, epidural's king, right? 84% incredibly effective, only 5% had no effect from the epidurals. An interesting piece is really that if you go in the non-pharmacologic area and look at bath or shower, almost 30% said it was very effective, and 50% said they got some effect from it. You can't do that if you have an epidural in your back, but if you're using nitrous, you can stop using the nitrous and then walk over and use the bath or shower. How about multiparous women? So again, epidural does much, much better than nitrous, but still, 50% rated it as very effective, 40% said they got some effect, and I think this is one of the big areas for nitrous. You have the woman come in, she's complete or nearly complete, you know she's going to deliver in the next 20 or 30 minutes. You can put on a mask with 50% oxygen, 50% nitrous, and she can really get some benefit from it. Another study, 1992 study. This is a study where they randomized patients in various order. So some started with oxygen, some started with various amounts of nitrous, and then they all went through the different groups at various times. They watched them for about 15 minutes in using each mixture. And what we have to the far left is just pure oxygen. This is pain scores on the y-axis. And in the darkened triangles, that's pain during a contraction. And in the open circles, that's pain in between contractions. So you see pain scores, up around 8 or so during a contraction with oxygen. You give intermittent small amounts of nitrous, 40%. If you drop this pain score just a tiny amount, 70%, like they're using in Australia intermittently. You drop it a little bit more. But the key here is really, if you deliver it continuously, 40% nitrous in this study can make a significant difference in the pain score and drop it. There were other studies that noted that if you breathe 40% nitrous continuously, it was nearly the same as breathing 70% intermittently. So this has been replicated a little bit in another study. So that's pain scores. Again, only 24 women in this study, by the way, but now we're going to look at some physiologic data. So again, now we're looking at heart rate. So we have in the darkened circles, again, during contractions, and then in the open blocks in between contractions. And you can see as you go from no nitrous on the left to more and more nitrous and then continuously delivered, you do notice a drop in the heart rate in both areas. So there is a little bit of a physiologic effect, I believe, from the pain mitigation, most likely. And then the arterial blood pressures also show the same trend. This is very small amounts. Notice that the y-axis does not go to 0. It just goes from 110 to 90. So they're really blowing up that really small amount, but it is there. Okay. This is another study in 1994 comparing just air and breathing 50% nitrous in oxygen. Okay. And what they did was they asked women to give pain scores with each contraction for a set of 5 contractions, and they would either start with nitrous and go to air or the other way around. And you notice in this study almost no difference in the pain scores. Now, one of the things was he had them start breathing it right at the onset of the contraction. So some would argue they didn't really have time for it to get to the midbrain. But at any rate, probably the most interesting part of this study was that even though these women gave pain scores that were identical to when they weren't using nitrous, the vast majority wanted to continue using the nitrous once the study period was done. All right, so now we're moving on from pain really more to just satisfaction and how women felt their birth experience went, their perception of their birth experience. And so we have a 1999 study, again from Europe, and we're looking at women who used nitrous, right, Demerol, or had epidural labor analgesia. And you can see the ones that used nitrous overall had a very positive experience, at least more than half did. Okay. This is a Listening to Mothers survey from 2002. Really interesting, 1,600 women had phone calls made to them during the year after they had delivered. And they did something very novel, which is they asked them, what did you use for your delivery and how well did it work? I have them lined up from top to bottom in what percentage rank things as very helpful. I have the pharmacologic methods in blue. So you see almost 80% said epidurals were extremely helpful for my labor pain relief. Nitrous, 30%. Now, one of the sad things or interesting things is that only 2% are using nitrous, right? We're in 2002. We've really dropped the amount of nitrous in the US, and these were all United States women that were questioned. I'm sort of surprised they even found 2% who were using nitrous. Opioids, the fentanyl that you use, is even worse than nitrous as far as women rating it as very helpful. Another really interesting thing is that the non-pharmacologic methods, tub immersion, shower, birthing ball, were rated better than nitrous and significantly better than fentanyl. And again, you're only going to be doing tub immersion and shower if you don't have an epidural in your back. Okay. Where can you use nitrous in the labor and delivery suite? So we talked a little bit about labor analgesia. Again, I think it's really beneficial for multips who come in and they're very close to delivery. It has been used for vacuum and forceps delivery. Usually a pudendal block is also placed, but it helps out. Placental removal, DNCs, the large episiotomy or second-degree lac repair for a woman who doesn't already have an epidural can be very beneficial. We've even used it at UCSF for women who just wouldn't tolerate an IV. We've given them a little nitrous for the IV stick. Okay. A little bit more for some of these. So again, the multiparous woman who's coming in at second stage almost, ready to push. This was a study comparing enflurane and nitrous, but we're just going to mainly concentrate on the nitrous column to the right. And we can see, again, small study just in 50 women, that given a chance to rate things as 1, 2, 3, or 4, where 3 and 4 are satisfactory pain relief, we have 76% of mothers who use nitrous in the second stage saying, yeah, it was actually satisfactory. Similar amounts of anesthesiologists who witnessed it, and then a little bit lower on the obstetricians. What about amnesia, forgetting the delivery experience? Well, 10% of the women who used 50% nitrous said they didn't remember their labor and delivery during that part. We don't have a control group who didn't use nitrous or enflurane. The interesting thing is in the discussion, the vast majority of these women did remember the actual baby being held by them. They just didn't remember the labor and delivery as much. And then when asked, would you have the same agent again? 86% of the women who had nitrous for the second stage, just the second stage, said, yeah, I would do it again this way. Okay. How about lac repair, perineal repair? This is an interesting study. It's a variety of reasons you would need to repair the perineum, from second-degree tears, episiotomies, labial tears, and so on. They compared using just 50% nitrous to using local infiltration of the tissue with 1% prilocaine. No real difference in the pain scores, a little bit lower on the nitrous when asked if they were satisfied with the anesthetic approach for their perineal repair, but not statistically significant. But still 77% said, yeah, the 50% nitrous was better, and there are a few obstetricians out there who say they can get a better repair if they don't infiltrate the tissue as much. All right, let's move on to maternal side effects. Now, I looked through a ton of literature, a variety of review articles, and that's why I have such huge ranges there, right? So nausea, 5 to 30%, dizziness, about the same, dysphoria, drowsiness, hazy memory. Serious adverse events. There was sort of a prospective study done out of France that had about 30,000 women involved in it, and that's where we get the serious adverse event rate of about 0.03. As far as my experience for almost 13 or 14 years at UCSF, I think the nausea is pretty low. I really don't notice that much difference between women on nitrous and women who are just in labor or have an epidural. I would put it closer to the 5% range of that. Dizziness and dysphoria, probably somewhere in 3 to 10, 5 to 10 range. Drowsiness, usually the pain keeps them awake. They're not that drowsy with nitrous. It's not that good as of an analgesic. And so hazy memory, I'd probably put it in the 5%, 10% like the study I quoted prior to this slide. Transient unconsciousness. As long as you only use nitrous and you're not mixing it with IV fentanyl, morphine sleep, other opioids, or anxiolytics, it's incredibly rare. A fairly recent review had it at 0.4%, and that's where I would put it. And the safety profile is really nice with nitrous because it's delivered by patient-held mask. If they do lose unconsciousness transiently, the mask will fall away within a couple of breaths, the nitrous is gone. And so it has a very nice safety profile. Contraindications, obviously, if your patient already has an impaired level of consciousness and can't hold a face mask, that would be a contraindication because it is patient-controlled delivery. Recent history of trauma where you might worry about a pneumothorax, but you've got bigger issues than epidurals or nitrous at that point in time. Same with the hemodynamic instability. There's a bit of a relative contraindication with B12 deficiency that you'll see why in just a moment. As far as adverse effects with labor and the neonate, so does nitrous cross to the baby? It's always asked by the mothers when we talk to them about various anesthetic options. If someone breathes nitrous who's pregnant, within 15 minutes, the child is at about 80% of the maternal blood level. So it crosses quite well. The interesting thing is children that are born to mothers who've used nitrous right up to the delivery. Within 3 minutes, basically all traces of it are gone within the child, and the child has levels of the baseline maternal blood levels prior to even using nitrous. So it goes away rather quick, whatever is left in the child. From the studies we have, and there were decent studies done on fetal heart rate, cord gases, APGARs, there's really no effect from nitrous, and one of the benefits is it can be used right up through the second stage. As far as newborn respiration and neonatal behavioral scores, we don't see any effect, but the reviews, and I agree with, we just don't have really good studies on that. It was mainly APGARs, cord gases, and fetal heart rates. As far as duration of delivery, mode of delivery, pretty good data on that, does not seem to affect that in any way. Okay. So the APGARs, the cord gases, fetal heart rate, these are all really short-term evaluations of effect. And so I really wanted to, again, remind us all about sort of the Sentinel article that came out in 2003, really that brought to light again, is there some long-term effect from the anesthetics we use? Now, this comes up much more in the pediatric anesthesiology literature. And as you know, this is primarily only in animal studies. But just to kind of review this initial study, this was a study that had a mixed anesthetic. There were opioids, there were halogenated agents, nitrous was used in there, benzodiazepines, and they looked at 7-day-old rats who got the anesthetic for a period of 6 hours. They saw apoptosis, widespread neurodegeneration, that's repeated in numerous animal studies, impaired long-term potentiation, and then in water maze tests, these rats had prolonged spatial recognition problems even 4 or 5 months out after this anesthetic had been delivered. Okay. What do we have regarding other studies? Not that much with just pure nitrous. We have some mouse and rat studies. I haven't seen any that used less than 75% nitrous in these animals. It was usually given for prolonged periods of time. Again, we're delivering 50%, 80% of that is making it to the fetus, so we're down around 40%. But the reason I really want to bring this up is because in the pediatric literature, one of the catch-22s is the child needs an anesthetic. You have to do something. And so what are you going to do? I mean, we have very little data on the effects in humans, let alone what agent's better than another or what time period's the best or so on like that. In obstetric anesthesia, we do have alternatives. And so although we have no clinical evidence at the moment that we shouldn't be using nitrous, and as far as I can tell, all the Scandinavians and Canadians and Brits seem to have the same mental facilities that the rest of us do, even though probably over half of them were delivered with nitrous. I think it really behooves us to keep an eye on this literature because we really don't know the answer at this point in time. And maybe we'll get it in the pediatric literature, but it's unclear if we'll ever be able to translate it to the in utero effect. Now, is there a mechanism? Yeah, there is a bit of a mechanism. So nitrous can work on activated B12, and B12 is key in the transition of homocysteine to methionine. And if you've inactivated the B12, you decrease the methionine levels. Why is that important? Because methionine works with folate, and that's important for making RNA and DNA and nerve development. There's also a cascade of events shown here in the picture that can also lead to apoptosis and cell death. So we do have a mechanism for nitrous, okay? But I think it was summed up really nicely by Takoa King and Cynthia Wong in an editorial to that ANA review in 2014, which says it may just be impossible to perform the human studies to address this. And when I inform women, I tell them a little bit about the animal studies, and I just say that we just lack data on this outcome. I tell them it's used all over Europe and Scandinavia, but the bottom line is we just don't know. Okay. So now we're going to sort of logistics. Should you decide to bring this on to your institution, we have nitrous available at every one of our labor and delivery suites. It can be hooked into the wall because we happen to have it piped into every labor and delivery suite. You just hook it up, you've got your oxygen, your nitrous, and most importantly, you have the scavenging system. Okay? You can also buy portable nitrous machines where you just put the little E-cylinders on. It delivers a set 50-50 mix. You can't change either one of these. It's always 50-50. And again, this equipment became available in about 2012, so I'd say in the past year I've had over a dozen groups contact me, the majority in the Bay Area, of how do we set this up and sort of going through this talk with them. But basically what you do is after you open the tanks or you plug it into the wall, you check your line pressures, you make sure they're appropriate, somewhere between 45 and 55. You then check the mix pressure and make sure it's appropriate between 30 and 35 psi, and that's what you need to do to make sure you're delivering the 50-50 mixture. Okay. So again, you want it to be 50-50, you don't want to mix other drugs with this. If you start mixing fentanyl with it, you allow the patient to have both fentanyl from the labor and delivery nurse as well as being on nitrous, they're going to have a higher chance of losing consciousness. It should be patient controlled. The anesthesiologist or the patient can hold it on, not the labor nurse, not the midwife, not the family member, right? Or you lose all your safety profile. It really is beneficial to educate the patient on how to use this effectively. Either breathe it continuously for periods during contractions or start breathing it at least 45 or 30 seconds before the contraction starts if it's well timed. And if they do that, then they'll actually get a little bit more analgesia and it'll be much more effective. Again, the scavenging system, we all know the dental literature with dental hygienists and nitrous being used there and they having bad birth outcomes from being exposed to it. With the scavenging system, it works really well. The face mask has basically a demand valve on it, sort of a second stage regulator for those who scuba dive, and only if it's sealed around the nose and mouth can it be delivered. It's not pumping nitrous into the room if it's not on the face of the mother. They exhale back into the mask. There's the scavenging system that's on. We've done part per million studies in our labor and delivery rooms where they're not anywhere near the 25 parts per million that OSHA recommends in the US. By the way, it's 100 in Europe. Family members, a really common question I get asked are, do family members abuse the nitrous? Do they grab it away from mother? We have never had that problem in our history at UCSF. I don't know, I think most family members are pretty respectful of the laboring woman in that suite, and they're not gonna grab the nitrous away. Can you bill for it? You absolutely can. There's your codes. And I'll just end with this comment by Takoa King, one of our outstanding nurse midwives. The story of how nitrous oxide is being reintroduced for benefit of women in the US is significant. Rediscovery can be as important, if not more important, than the original discovery. And I really think it is in order to get more research going. So thank you for sticking around.